You are not tired because you are old. You are tired because your body has been sending you the same distress signal every single morning for years, and you have been calling it aging. That is the first lie you need to stop telling yourself. Right now. Today. Every morning. Before your feet hit the floor. Before you reach for the coffee. Before you remind yourself that this is just what 60 feels like. Your body has already completed a 12-hour biological evaluation of every system that keeps you alive. Your cardiovascular system, your hormonal architecture, your cellular repair mechanisms, your neurological recovery processes, your metabolic engine. And the exhaustion you feel the moment you open your eyes is not a verdict on your age. It is a report card on what is happening inside your body while you sleep. Or more accurately, what is failing to happen. Here is the brutal truth that no one in your life has had the courage to tell you. The fatigue you wake up with every morning is not inevitable. It is not written into your genetic code. It is not an unavoidable tax on the privilege of reaching your 60s. It is a symptom. A specific, identifiable, clinically measurable symptom of biological processes that are either working correctly or working against you. And in the overwhelming majority of Americans over 60 who wake up exhausted every single day, those processes are working against them for reasons that are entirely identifiable, entirely addressable, and entirely within the reach of the information you are going to receive in the next 60 minutes. Stop accepting exhaustion as a condition of your age. Start treating it as information, because that is exactly what it is. And today, we are going to decode that information completely. Here is something that will fundamentally change how you think about the fatigue you wake up with every morning. Sleep is not rest. Sleep is work. Intensive, biologically critical, irreplaceable work that your body performs on every organ system, every neural circuit, every hormonal pathway, and every cellular structure you possess. Work that can only happen when you are unconscious, when the body's resources are fully redirected away from the demands of waking life and focused entirely on the maintenance, repair, and optimization of the biological machinery that keeps you functional. When you wake up exhausted, you are not waking up from inadequate rest. You are waking up from inadequate biological work. Something, or multiple things, interrupted, shortened, or degraded the quality of the work your body was attempting to do while you slept. And the exhaustion is the direct physiological consequence of that incomplete biological maintenance. To understand what is going wrong, you need to understand how sleep is architected in the healthy adult brain, and how that architecture changes dramatically and consequentially after the age of 60. Sleep is not a uniform, homogeneous state of unconsciousness. It is a highly structured, cyclically organized process composed of distinct stages, each with specific and irreplaceable biological functions, cycling through a characteristic sequence approximately 4 to 6 times across a normal night of sleep. The sleep cycle consists of 3 stages of non-rapid eye movement sleep, called N1, N2, and N3, followed by rapid eye movement sleep, commonly abbreviated as REM sleep. Each complete cycle lasts approximately 90 minutes in healthy adults. And the relative proportion of each stage within these cycles changes across the night in a highly characteristic way, with the earlier cycles of the night dominated by N3 sleep, the deepest and most physically restorative stage, and the later cycles dominated by increasingly prolonged REM sleep, the stage most closely associated with memory consolidation, emotional processing, and cognitive function. N3 sleep, also called slow-wave sleep or deep sleep, is the stage during which the most critical physical restoration occurs. Growth hormone, the primary anabolic hormone responsible for tissue repair, muscle protein synthesis, immune system restoration, and cellular regeneration, is secreted in its largest pulses almost exclusively during N3 sleep. The glymphatic system, the brain's waste clearance mechanism, which flushes amyloid beta and tau proteins from brain tissue, operates at its highest efficiency during N3 sleep. Immune system consolidation, inflammatory regulation, and metabolic restoration All occur predominantly during this stage. REM sleep is the stage during which the brain processes and consolidates the memories and emotional experiences of the preceding day. It is the stage most directly associated with the psychological experience of dreaming, and it is the stage whose disruption most directly produces the specific symptoms of emotional dysregulation, cognitive fog, and impaired concentration that many people over 60 experience as part of their morning fatigue profile. Now here is the first shocking truth you need to confront directly. After the age of 60, slow-wave sleep, N3, the most physically restorative stage, the stage during which growth hormone is released, the stage during which the brain clears itself of neurodegenerative proteins, declines by 50 to 80% compared to young adult levels. Not 5%, not 10%, 50 to 80%. You are sleeping the same number of hours you slept at 45, or close to it. But the biological work being accomplished during those hours is a fraction of what it once was. You are putting in the time. Your body is not completing the job. And every morning, the exhaustion you feel is the accumulated deficit of biological maintenance work that your body attempted and failed to complete. This is not aging. This is a specific, measurable, mechanistically understood deterioration in sleep architecture, with identifiable causes, specific contributing factors, and targeted interventions that can meaningfully restore the depth and restorative quality of sleep even in adults in their 60s, 70s, and beyond. The question is not whether anything can be done about it. The question is whether you are willing to understand what is causing it and do what the evidence actually shows works. There are 5 specific biological mechanisms that hijack sleep architecture after 60, silently, progressively, and without any dramatic warning, gradually stripping the depth and restorative power from your sleep over years, while you attribute the consequences to aging and do nothing. You are going to know all 5 of them by the time this section ends. The first hijacker, the circadian clock collapse. Every biological process in your body, sleep, wakefulness, hormone secretion, body temperature, immune function, metabolism, is regulated by an internal timing system called the circadian clock. This clock is anchored to the external day-night cycle primarily through light exposure received by specialized photoreceptive cells in the retina that signal directly to the master circadian pacemaker in the hypothalamus, a structure called the suprachiasmatic nucleus. In young adults, this circadian timing system is robust, precisely synchronized, and highly responsive to environmental light cues. The morning cortisol surge arrives reliably. The evening melatonin secretion begins at a consistent time. The nocturnal growth hormone release occurs with reliable magnitude. And the architecture of sleep, the precise cycling of N3, N2, and REM in their characteristic proportions, is organized and maintained by the circadian clock with surgical precision. After 60, the suprachiasmatic nucleus undergoes measurable neuronal loss and reduced amplitude of circadian signaling. The circadian clock weakens. The signals it sends to the downstream biological systems it regulates, including the sleep-wake system, become less precise, less powerful, and more susceptible to disruption. The result is a progressive desynchronization of the circadian system. The morning cortisol surge blunts and shifts unpredictably. Evening melatonin secretion begins later, at lower concentrations, and with reduced reliability. The consolidated, architecturally precise sleep of younger adulthood fragments into lighter, more frequently interrupted sleep with reduced slow-wave content. And here is what makes this particularly important for the morning fatigue you experience. This circadian desynchronization does not just impair sleep quality. It impairs the precise temporal coordination between specific sleep stages and the hormonal events that accompany them. Growth hormone release, which is normally locked to the first slow-wave sleep episode of the night, becomes dissociated from sleep architecture, reducing in magnitude and reliability. Cortisol, which should remain suppressed throughout the night and rise sharply and cleanly in the morning, begins to show inappropriate nocturnal elevation, fragmenting sleep at the precise times when the deepest and most restorative slow-wave sleep would otherwise be occurring. This is the fundamental timing system of your biology breaking down, and the morning exhaustion is its most visible daily symptom. The second hijacker, obstructive sleep apnea. Obstructive sleep apnea is the single most prevalent and most consequential undiagnosed medical condition contributing to morning fatigue in Americans over 60. Its prevalence in adults over 65 is estimated at 30 to 40%. The majority of affected individuals have never been diagnosed, have never been evaluated, and have no idea that they have it. The mechanism is precise and devastating. During sleep, the muscles of the upper airway, the pharyngeal muscles, the tongue, the soft palate, relax as part of the normal physiological transition to sleep. In individuals with obstructive sleep apnea, this relaxation is excessive, allowing the soft tissue structures of the upper airway to collapse and obstruct airflow during sleep. The brain detects the resulting oxygen desaturation and triggers a protective arousal response. A brief awakening that restores muscle tone, reopens the airway, and reestablishes breathing. These arousals last only seconds. They are almost never consciously remembered, but they occur in untreated moderate to severe obstructive sleep apnea, anywhere from 15 to over 60 times per hour throughout the night. Every single apnea event fragments sleep architecture. Every arousal prevents the consolidation of slow-wave sleep by interrupting the sustained slow oscillatory brain activity that characterizes N3. Every oxygen desaturation triggers a cortisol pulse and a sympathetic nervous system activation that further disrupts the hormonal environment of the sleeping brain. And every hour of fragmented apnea-interrupted sleep produces the same degree of sleep deprivation and architectural disruption as an hour less sleep, meaning that an individual sleeping 7 hours with untreated moderate severe sleep apnea may be receiving the biological restoration equivalent of 4 hours of consolidated, architecturally normal sleep. You sleep 7 hours, you wake up exhausted, and you conclude that you simply do not sleep well anymore. You may have obstructive sleep apnea, and it may be destroying your sleep, your cardiovascular health, your cognitive function, and your metabolic health every single night, while you attribute the consequences to aging. The diagnostic evaluation for obstructive sleep apnea is more accessible than most people realize. Home sleep testing, in which a small monitoring device is worn on the wrist or finger during a normal night of sleep at home, can diagnose obstructive sleep apnea without the inconvenience of an overnight laboratory sleep study, and is widely covered by Medicare and most private insurance plans for individuals with appropriate clinical indications. Treatment with continuous positive airway pressure therapy, CPAP, has been shown in multiple randomized controlled trials to produce dramatic and rapid improvements in subjective and objective sleep quality, daytime energy, cognitive function, and morning fatigue in individuals with obstructive sleep apnea. If you wake up tired every morning, particularly if you snore, if you experience morning headaches, if your bed partner has observed breathing pauses during your sleep, if you notice excessive daytime sleepiness or the need for daytime napping, you need a conversation with your physician specifically about obstructive sleep apnea. Today, not at your next annual physical. Today. The third hijacker, hormonal collapse. The hormonal environment of the sleeping body after 60 is dramatically different from that of the sleeping body at 40, and the specific hormonal changes that occur with age directly and substantially impair the depth, continuity, and restorative quality of sleep. Growth hormone, as established in the previous section, is secreted predominantly during slow-wave sleep, and its secretion declines by approximately 70 to 80% between young adulthood and the 7th decade of life. But the relationship between growth hormone and slow-wave sleep is bidirectional. Reduced slow-wave sleep reduces growth hormone secretion, and reduced growth hormone availability contributes to lighter, more fragmented sleep architecture, creating a self-reinforcing cycle of declining sleep quality and declining growth hormone that accelerates with each passing decade. Melatonin, the hormone produced by the pineal gland in response to darkness that signals the brain and body to prepare for sleep, declines substantially in both its peak concentration and its duration of nocturnal secretion with age. By the 7th decade, melatonin production in many individuals has declined to approximately 10 to 20% of young adult levels, insufficient to generate the strong, sustained circadian sleep signal that anchors consolidated, deep sleep in younger adults. In women, the loss of estrogen and progesterone at menopause, the precise hormonal transition that drives the redistribution of visceral fat we discussed in our previous video, also directly impairs sleep architecture. Progesterone, in particular, has direct sleep-promoting effects through its action on GABAA receptors in the brain. The dramatic loss of progesterone at menopause removes this direct sleep-promoting signal, contributing to the insomnia, sleep fragmentation, and hot flash-related sleep disruption that affect the majority of postmenopausal women and persist well into the 6th and 7th decades. In men, declining testosterone, the same progressive hormonal decline we discussed in detail in our video on erectile dysfunction, contributes to reduced slow-wave sleep through mechanisms that include the established relationship between testosterone and sleep architecture, particularly through testosterone's influence on the upper airway musculature, with testosterone deficiency contributing to increased upper airway collapsibility and worsened sleep apnea in some affected men. The 4th hijacker, pain and physical discomfort. Chronic pain, from osteoarthritis, from degenerative disc disease, from neuropathy, from the accumulated musculoskeletal burden of decades of physical life, is one of the most consistently underestimated contributors to disrupted sleep architecture in adults over 60. Pain activates the same arousal systems as obstructive sleep apnea, fragmenting slow-wave sleep, generating sympathetic nervous system activation, triggering cortisol release, producing the same pattern of architecturally disrupted, restorative deficient sleep through a completely different physiological mechanism. The relationship between pain and sleep disruption is bidirectional and self-reinforcing in ways that make it particularly consequential. Disrupted sleep reduces pain tolerance. Multiple studies have demonstrated that even a single night of poor sleep significantly lowers pain thresholds. Reduced pain tolerance worsens the pain that disrupts sleep. The sleep disruption produced by pain reduces the tissue repair and anti-inflammatory processes that would otherwise contribute to pain reduction. And the cumulative sleep deficit amplifies the psychological experience of pain through its effects on the emotional processing circuits of the prefrontal cortex and amygdala. This bidirectional pain-sleep cycle is self-perpetuating and progressive, and it is one of the most clinically important reasons why optimal management of chronic pain conditions is not merely a quality-of-life issue for adults over 60, but a direct sleep health and cognitive health issue as well. The 5th hijacker, medication side effects. The average American over 65 takes between 4 and 7 prescription medications simultaneously, and multiple medications in the most commonly prescribed categories in the senior population exert direct, pharmacologically specific disrupting effects on sleep architecture. Beta blockers, prescribed for hypertension and cardiovascular protection, reduce melatonin secretion through their blockade of the beta-adrenergic receptors involved in pineal melatonin synthesis, contributing to difficulty initiating sleep and reducing total sleep time in some individuals. Some beta blockers also suppress REM sleep, contributing to the specific cognitive and emotional consequences of REM disruption. Diuretics, prescribed for hypertension, heart failure, and edema management, produce nocturnal urination that fragments sleep at the most critical periods of slow-wave sleep consolidation, with the frequency of nocturnal awakening directly proportional to the severity of the diuretic's effect on urine production timing. Corticosteroids, prescribed for inflammatory conditions including arthritis, chronic obstructive pulmonary disease, and numerous other conditions prevalent in the older population, directly suppress slow-wave sleep and disrupt the normal nocturnal decline in cortisol, creating a pharmacologically induced version of the same cortisol dysregulation that drive sleep disruption in the context of chronic psychological stress. Certain antidepressants, particularly selective serotonin reuptake inhibitors, suppress REM sleep through their serotonergic mechanisms, contributing to the specific cognitive and emotional consequences of REM disruption discussed throughout this section. And perhaps most ironically, many commonly used sleep aids, including the antihistamine-based over-the-counter sleep medications widely used in the senior population, actually suppress slow-wave sleep, producing sedation without the restorative architecture of genuine deep sleep. You fall asleep faster, but the biological work of sleep does not get done, and you wake up the next morning feeling as though you slept, because you were unconscious, but as exhausted as though you had not, because your body did not complete its maintenance work. Stop. Before we go any further, you need to confront 3 lies. Lies that you have been telling yourself about your sleep, that the people around you have been reinforcing, and that have been keeping you locked in the pattern of morning exhaustion that you have come to accept as inevitable. Lie number 1. Older people simply need less sleep. This is perhaps the most pervasive and most consequential sleep myth in the aging population. You have heard it so many times from so many sources, including, shamefully, from physicians who should know better, that you have integrated it as an unquestioned fact of biology. It is not a fact. It is a misinterpretation of a real phenomenon, and the difference between the phenomenon and the misinterpretation has enormous clinical consequences. What is true is that older adults frequently sleep fewer hours than younger adults. What is also true is that older adults frequently report feeling more satisfied with less sleep, or report needing to wake earlier and being unable to return to sleep. What is not true is that these observations reflect a reduced biological requirement for sleep. What the research actually demonstrates is that older adults frequently obtain less sleep because the biological mechanisms that generate and sustain consolidated, deep sleep become less effective with age, not because the body's need for sleep has diminished. The tissue repair, the hormone secretion, the immune restoration, the glymphatic clearance, the memory consolidation, none of these biological requirements diminishes with age. If anything, the aging body's need for the restorative work of sleep becomes more critical, not less, precisely because the biological systems performing that work become progressively less efficient and require more support. When an older adult sleeps fewer hours and feels subjectively acceptable about it, they are not demonstrating a reduced sleep need. They are demonstrating a reduced capacity to feel the full subjective impact of sleep deprivation, a phenomenon documented in sleep deprivation research, in which older adults consistently underestimate their degree of impairment relative to objective neuropsychological testing of the same impairment. You feel less terrible than you should. That does not mean you are fine. Lie number 2. If I am not tossing and turning, I am sleeping well. The second lie is the conflation of time spent in bed with time spent in restorative sleep. You lie down, you close your eyes, you lose consciousness, you wake 8 hours later, and you conclude that you slept 8 hours. But as established in the previous sections, the architecture of what happens between closing your eyes and opening them again is infinitely more consequential than the raw duration of unconsciousness. 8 hours of fragmented, slow-wave deficient, apnea-interrupted cortisol-elevated sleep produces the same morning exhaustion as 4 hours of sleep, and in some respects produces worse cognitive and physical consequences, because the subjective experience of having spent 8 hours in bed creates the false reassurance that sleep was adequate, preventing the recognition and investigation of the true problem. You are not sleeping well just because you are sleeping long. Duration and quality are not the same variable, and confusing them has kept millions of Americans over 60 from seeking evaluation for conditions: obstructive sleep apnea, restless leg syndrome, circadian rhythm disorders, that are robbing the quality from their sleep while leaving the duration superficially intact. Lie number 3, there is nothing I can do about it. This is the most paralyzing lie of all, and it is the one most directly responsible for the continued, preventable daily exhaustion of millions of Americans over 60 who have simply accepted the morning fatigue as their permanent reality. There is something you can do about it. Specific things. Evidence-based, clinically validated, mechanistically understood things that directly address the 5 biological hijackers identified in the previous section. The correct response to the morning fatigue you have been experiencing is not acceptance. It is investigation and intervention. And the remainder of this video is going to give you the specific framework for both. There is a consequence of chronically disrupted sleep architecture in adults over 60 that extends beyond daily fatigue, a consequence that operates silently, accumulates invisibly, and whose full clinical significance is only now beginning to be appreciated by the scientific community. It is the glymphatic debt. As discussed in our previous video on brain health, the glymphatic system is the brain's waste clearance mechanism, the network of perivascular channels through which cerebrospinal fluid flushes metabolic waste products from brain tissue during sleep, including, most critically, amyloid beta and tau proteins, the same pathological proteins whose progressive accumulation in brain tissue defines the neuropathology of Alzheimer's disease. Glymphatic clearance is most active during slow-wave sleep, which means that every night your slow-wave sleep is inadequate, fragmented by sleep apnea, suppressed by medications, disrupted by pain, degraded by circadian desynchronization. Your brain retains a larger proportion of the amyloid beta and tau that would otherwise be cleared. One night of poor sleep produces a measurable increase in brain amyloid beta concentration, documented by positron emission tomography imaging in human subjects following a single night of experimental sleep deprivation. One night. Now extrapolate that finding across 5 years of the fragmented, slow-wave deficient sleep that the majority of Americans over 60 are experiencing every night. This is not a theoretical concern. This is a measurable, imaging-confirmed accumulation of the very substances implicated in the pathological cascade leading to Alzheimer's disease, occurring nightly, silently, in the brains of millions of older Americans who have been told that their disrupted sleep is simply an unavoidable consequence of aging. The morning exhaustion you feel is not just today's problem. It is the daily symptom of a process that is leaving a cumulative biological debt in the neural architecture of your brain, a debt that compounds with each inadequate night, and that represents one of the most compelling reasons to treat the morning fatigue you have normalized with the urgency it genuinely deserves. This is not meant to frighten you. It is meant to motivate you, because the glymphatic debt is not irreversible. The system that produces it is responsive to intervention. Every improvement in slow-wave sleep quality, every additional minute of consolidated N3 sleep achieved through the interventions discussed in the following sections, translates directly into improved glymphatic clearance, reduced nightly amyloid accumulation, and a measurable shift in the trajectory of cognitive aging. You are not passively watching your brain age. You are actively, through the quality of sleep you protect or fail to protect, determining the rate at which your brain either accumulates or clears the biological burden of neurodegeneration. That is a fact. And it changes the weight of what we discuss for the remainder of this video. The morning fatigue of chronically disrupted sleep architecture is not a self-contained problem. It is the visible daily symptom of a broader physiological disruption that extends its consequences into every major organ system, consequences that compound and interact with the cardiovascular, metabolic, and hormonal changes discussed in our previous videos, in ways that make the cumulative health impact of disrupted sleep in the aging adult far more serious than morning tiredness alone. The metabolic consequences are direct and mechanistically established. Chronic sleep insufficiency and poor sleep architecture produce significant impairments in glucose metabolism, specifically reductions in insulin sensitivity and impaired glucose tolerance that are measurable even after a single night of restricted or fragmented sleep, and that become progressively more severe with chronic sleep disruption. A study published in the Annals of Internal Medicine demonstrated that reducing sleep from 8.5 hours to 5.5 hours for 2 weeks in healthy young adults producing, in accelerated form, the same degree of sleep restriction experienced chronically by many older adults, produced a 25% reduction in insulin sensitivity, a reduction of the same magnitude as that produced by gaining approximately 10 kilograms of body fat. In adults over 60 who are already contending with the age-related insulin resistance, sarcopenia-driven metabolic rate decline, and visceral fat accumulation mechanisms discussed in our previous video, the additional insulin sensitizing impairment produced by chronically disrupted sleep creates a profoundly hostile metabolic environment, one in which the management of blood sugar, the prevention of type 2 diabetes, and the reversal of visceral fat accumulation becomes substantially more difficult, regardless of the dietary and exercise interventions implemented during waking hours. The cardiovascular consequences are equally direct and equally serious. The overnight period, during which blood pressure normally decreases by 10 to 20% below daytime levels in a phenomenon called nocturnal dipping, is a period of critical cardiovascular restoration. This nocturnal blood pressure dip reduces the mechanical stress on the arterial walls, allows endothelial repair mechanisms to operate with reduced hemodynamic interference, and provides a daily period of reduced cardiovascular demand that contributes meaningfully to long-term cardiovascular health. Disrupted sleep, and particularly obstructive sleep apnea, with its cyclical oxygen desaturations and sympathetic nervous system activations, abolishes this nocturnal blood pressure dip, producing a pattern called non-dipping or reverse dipping, in which blood pressure remains elevated or actually increases during sleep relative to daytime levels. This non-dipping pattern is independently associated with substantially increased risk of cardiovascular events, stroke, and chronic kidney disease, with the magnitude of risk elevation comparable to having a systolic blood pressure 20 millimeters of mercury higher during waking hours. The cardiovascular consequences of poor sleep quality after 60 are not separate from the cardiovascular concerns we have discussed in our previous videos on blood pressure and peripheral vascular disease. They are additive, synergistic, and in many cases, the disrupted sleep itself represents an unaddressed cardiovascular risk factor that is limiting the effectiveness of the pharmacological and lifestyle interventions being applied in its presence. Cortisol, the stress hormone whose dysregulation we have now discussed in the context of visceral fat accumulation, cognitive health, and circadian rhythm disruption, reaches its most directly damaging expression in the context of chronic sleep disruption. Every night of fragmented sleep suppresses the normal nocturnal cortisol nadir and amplifies the following morning's cortisol awakening response. Chronically elevated cortisol drives visceral fat accumulation, impairs insulin sensitivity, promotes arterial inflammation, suppresses hippocampal neurogenesis, and contributes to the anxiety, irritability, and emotional dysregulation that many chronically sleep-deprived older adults experience as part of their daily reality. The exhaustion you wake up with every morning is not just tiredness. It is the daily experience of a body operating under the cumulative physiological burden of disrupted hormonal coordination, impaired metabolic regulation, elevated cardiovascular stress, and accelerated neurological aging. And every day that passes without addressing the underlying causes is a day in which that cumulative burden grows heavier. Here is the conversation you need to have with your physician, not at some vague point in the future, at your next appointment, this week if possible. Because the morning fatigue you have been experiencing is not a complaint to be sympathetically acknowledged and sent home with a recommendation to practice good sleep hygiene. It is a clinical symptom requiring systematic evaluation, the same systematic evaluation that your physician would apply to unexplained chest pain or unexplained weight loss or any other symptom that carries the potential to reflect serious underlying pathology. And the morning fatigue of an adult over 60 who is sleeping the expected number of hours but waking exhausted every day carries exactly that potential. The clinical evaluation of morning fatigue in this population should include the following specific components: a complete review of all current medications, with specific attention to beta blockers, diuretics, corticosteroids, antidepressants, antihistamines, and any other agents with documented effects on sleep architecture, melatonin secretion, or nocturnal arousal patterns. The question to bring to your physician is not simply whether your medications cause drowsiness. The question is whether any of your current medications are suppressing slow-wave sleep, fragmenting sleep continuity, producing nocturnal urination, or disrupting the hormonal environment of the sleeping brain. A specific evaluation for obstructive sleep apnea, not simply a general inquiry about snoring or tiredness, but a formal clinical assessment using validated screening tools such as the Stop-Bang questionnaire, followed by home sleep testing or polysomnography if the screening evaluation indicates elevated risk. If you snore, if you wake with morning headaches, if you experience excessive daytime sleepiness, if your bed partner has observed breathing pauses during your sleep. Any one of these is sufficient to warrant formal sleep apnea evaluation, and their presence should not be ignored or minimized in the clinical encounter. A comprehensive hormonal evaluation, including thyroid-stimulating hormone, which screens for both hypothyroidism and hyperthyroidism, either of which can dramatically disrupt sleep architecture. Morning cortisol, to assess for both adrenal insufficiency and hypercortisolism. In men, a morning total testosterone and sex hormone binding globulin, given the established relationship between testosterone deficiency and sleep quality. In postmenopausal women, a discussion of the relationship between the hormonal changes of menopause and sleep quality, and of the evidence base for the various pharmacological and non-pharmacological interventions available to address this relationship. An evaluation for restless leg syndrome and periodic limb movement disorder, conditions that are substantially more prevalent in the older population than is commonly recognized, that produce the specific patterns of sleep onset difficulty, nocturnal limb discomfort, and fragmented sleep that many affected individuals attribute to anxiety or general insomnia, and that respond well to specific pharmacological and non-pharmacological interventions once correctly diagnosed. A pain assessment, specifically addressing whether chronic pain conditions are contributing to sleep fragmentation, and whether the current pain management regimen is adequately controlling nocturnal pain to allow consolidated, architecturally normal sleep. This is not an unreasonably demanding clinical agenda. It is the minimum evaluation that the symptom of morning fatigue in an adult over 60 deserves. And if your physician dismisses your morning fatigue as simply part of aging, without conducting this evaluation, you have the right to push back. You have the right to ask specifically about sleep apnea evaluation, about medication effects on sleep, about hormonal assessment. You have the right to be referred to a sleep medicine specialist if the evaluation in the primary care setting does not produce actionable clinical answers. Your morning exhaustion is information. It deserves to be investigated with the clinical rigor that it represents. Let us now move from diagnosis to intervention, from understanding why you wake up exhausted to the specific, evidence-based, mechanistically grounded practices that directly address the biological hijackers identified earlier, and that the research most strongly supports for restoring the depth, continuity, and restorative quality of sleep after 60. Intervention. 1. Circadian anchoring. Addressing the circadian desynchronization that undermines sleep architecture after 60 requires a specific and consistent set of environmental and behavioral practices that strengthen the weakened circadian signal and re-anchor the biological clock to the external day-night cycle. The single most powerful circadian anchoring intervention is fixed sleep and wake timing, maintaining precisely consistent bedtimes and wake times 7 days a week, including weekends, regardless of how the previous night's sleep felt. This consistency provides the most powerful behavioral signal available for stabilizing the circadian system, because the circadian clock calibrates itself using the temporal pattern of sleep-wake transitions as a primary entrainment cue. Sleeping in on weekends, even by 1 to 2 hours, produces a phenomenon called social jet lag that desynchronizes the circadian clock by the equivalent of crossing 1 to 2 time zones every weekend, contributing to the Sunday night sleep difficulty and Monday morning fatigue that many older adults experience as a regular weekly pattern. Fix your wake time every day, without exception. This is the single most impactful circadian intervention available: morning light exposure. Specifically, exposure to bright natural light within 30 to 60 minutes of waking is the most powerful environmental signal for circadian entrainment available. Light entering the retina activates the melanopsin-containing photoreceptive cells that signal the suprachiasmatic nucleus, resetting the circadian pacemaker and anchoring the downstream hormonal and neurological rhythms of the day. Morning outdoor exposure for even 15 to 20 minutes, even on overcast days, which still provides substantially more light intensity than typical indoor environments, produces measurable improvements in circadian synchronization, evening melatonin onset, sleep onset latency, and slow-wave sleep proportion in older adults. Evening light management, reducing bright light exposure in the 2 to 3 hours before the target bedtime, specifically the blue wavelength light emitted by television, computer, tablet, and smartphone screens that most potently suppresses melatonin secretion, complements the morning light anchoring strategy, and directly improves the reliability of the melatonin-mediated sleep onset signal. Intervention 2. Thermal sleep environment. Optimization core. Body temperature follows a precise circadian rhythm, declining in the evening hours as part of the physiological preparation for sleep, reaching its nadir during the mid-sleep period, and rising in the late sleep period as part of the morning arousal process. This nocturnal temperature decline is not merely a consequence of sleep. It is an active physiological process that is both required for sleep onset and maintained throughout the night by the cardiovascular and thermoregulatory systems to support sleep continuation. The sleeping environment temperature directly influences the quality of this nocturnal temperature regulation, and the optimal range for sleep quality is substantially cooler than most people maintain their bedrooms, particularly the bedrooms of older adults who frequently prefer warmer sleeping environments based on comfort preferences developed during waking hours. Multiple controlled studies have demonstrated that a bedroom temperature between 65 and 68 degrees Fahrenheit produces significantly better objective sleep architecture compared to temperatures above 70 degrees, including significantly greater proportions of slow-wave sleep, shorter sleep onset latency, fewer nocturnal awakenings, and improved sleep efficiency. For postmenopausal women experiencing nocturnal hot flashes, a cooling mattress pad or cooling bedding that actively manages sleep surface temperature represents a directly targeted intervention for one of the most disruptive contributors to their specifically disrupted sleep architecture. Intervention 3. The exercise-sleep synergy. As established in our previous video on brain health, regular moderate-intensity aerobic exercise, performed consistently, ideally in the morning hours, is among the most consistently supported behavioral interventions for improving slow-wave sleep proportion in adults over 60. The mechanisms are multiple. Aerobic exercise increases the homeostatic sleep drive, the progressively increasing pressure for sleep that builds throughout the waking day as a function of adenosine accumulation in the brain, and that produces the deepest, most consolidated, most slow-wave enriched sleep during the subsequent night, when the accumulated adenosine is metabolically cleared during sleep. Exercise also reduces cortisol and anxiety, reducing the hyperarousal that is the most common physiological antagonist of sleep onset and sleep consolidation in the older adult population. And the circadian benefits of morning exercise and light exposure discussed in the previous section directly address the circadian desynchronization mechanism identified as the first major biological hijacker of sleep quality after 60. Intervention 4. Targeted nutritional timing. The timing and composition of evening nutrition exerts a direct and measurable influence on sleep architecture through effects on core body temperature, insulin secretion, gut microbiome signaling, and amino acid availability for the synthesis of sleep-promoting neurotransmitters. Evening meals consumed within 3 hours of the target bedtime produce digestive metabolic activity and associated core body temperature elevation that interfere with the nocturnal temperature decline required for optimal sleep onset and slow-wave sleep consolidation. For individuals experiencing sleep onset difficulty, advancing the evening meal to at least 3 hours before the target bedtime represents a zero-cost, immediately implementable intervention that directly addresses this physiological contributor. Tryptophan, an essential amino acid and the direct precursor to serotonin and melatonin, when consumed in the evening in appropriate food sources or supplement form, supports the biosynthesis of both serotonin and the melatonin derived from serotonin, potentially enhancing the melatonin signal, whose age-related decline contributes to sleep architecture disruption. Food sources rich in tryptophan appropriate for evening consumption include turkey, eggs, dairy products, walnuts, and seeds. Low-dose melatonin supplementation at doses of 0.5 to 1 milligram taken 30 to 60 minutes before the target bedtime has been shown in multiple randomized controlled trials to specifically improve sleep onset latency and sleep quality in older adults with demonstrated melatonin deficiency, without producing the next-day grogginess or tolerance development associated with higher doses or pharmacological sleep agents. The emphasis on low dose is important. The physiological replacement dose for age-related melatonin deficiency is substantially lower than the 3 to 10 milligram doses commonly sold in supplement formulations, and higher doses do not produce proportionally greater benefit while potentially disrupting the physiological melatonin signaling pattern. Intervention. 5. Cognitive arousal management, the hyperarousal state. The persistent activation of the brain's vigilance and threat monitoring systems that prevents the smooth transition from wakefulness to sleep and from light sleep to deep sleep is one of the most prevalent and most clinically important contributors to the disrupted sleep architecture of adults over 60, operating through mechanisms that are distinct from and additive to the biological hijackers discussed earlier. Cognitive arousal management, the deliberate application of evidence-based techniques for reducing the hyperarousal state in the pre-sleep period, represents a specific and clinically validated approach to this contributor, with effectiveness for certain patterns of sleep disruption comparable to that of pharmacological sleep agents, without the dependency, tolerance, and sleep architecture disrupting side effects associated with those agents. Stimulus control therapy, the systematic restriction of the bed and bedroom to sleep and intimacy only, removing all waking activities including reading, television viewing, and telephone use from the sleep environment, reconditions the association between the bed and sleep, reversing the learned arousal association that develops when the bed becomes associated with wakefulness, worry, and frustrated sleep attempts. Sleep restriction therapy, a counterintuitive but highly effective technique in which time spent in bed is initially restricted to match actual sleep time, then progressively extended as sleep efficiency improves, concentrates the homeostatic sleep drive, producing deeper and more consolidated sleep within the constrained sleep window, then gradually restoring normal sleep duration as the sleep-bed association strengthens. Here is where this conversation gets uncomfortable, because everything discussed so far has been information, and information without honest self-assessment is just entertainment. So this section is not about new mechanisms or new interventions. This section is about the specific behaviors, the daily choices you are making right now, today, that you are either not recognizing as sleep destructive or that you are recognizing and choosing to continue anyway, that are contributing directly to the morning exhaustion you wake up with every day. You are going to confront each one directly, not with compassion, with clarity. Behavior. 1. The late screen. You are watching television in bed. You are scrolling your phone after 10 o'clock at night. You know that the blue light suppresses melatonin. You have heard it before. You do it anyway, because the entertainment provides a pleasant transition to sleep, and because stopping feels like an unnecessary inconvenience. Here is the reality. Every 30 minutes of bright screen exposure after 9 o'clock in the evening delays melatonin onset by 30 to 45 minutes, reduces total melatonin secretion by 15 to 20%, and reduces slow-wave sleep in the first half of the night by a measurable and significant degree. You are choosing the 30 minutes of television. Your body is paying for it with impaired glymphatic clearance, reduced growth hormone secretion, and the morning exhaustion that you then attribute to aging. The screen goes off at least 90 minutes before your target bedtime. Not sometimes, every night. If this feels impossible, it is because you have not yet genuinely confronted the biological cost of the choice you are making. Behavior 2, the inconsistent schedule. You sleep until 8 or 9 on Saturday and Sunday because you feel you deserve it after the week. You go to bed at 11 on weekdays and midnight or later on weekends. You take naps of unpredictable duration at unpredictable times when fatigue peaks during the day. Every one of these behaviors undermines the circadian anchoring that is the foundation of consolidated, architecturally normal sleep. The social jet lag produced by weekend schedule variation has been measured to shift the circadian phase by 1 to 2 hours, producing Sunday night insomnia and Monday morning exhaustion as reliable as clockwork in individuals with this pattern. You want to sleep better, but you are not willing to sleep at consistent times. These two things are incompatible. Choose one. Behavior 3. The unchallenged snoring. You snore. Your bed partner has mentioned it. You have perhaps noticed that you wake up with a dry mouth or a morning headache with some regularity. You have attributed it to sleeping position, to congestion, to the normal sounds of an aging body. You have not been evaluated for obstructive sleep apnea because the evaluation feels inconvenient, because the treatment, CPAP, sounds uncomfortable, because it is easier to normalize the symptom than to investigate the cause. Meanwhile, your sleep apnea, if present, is fragmenting your sleep architecture hundreds of times per night. It is elevating your nocturnal blood pressure. It is generating cortisol pulses that impair the following day's insulin sensitivity. It is preventing the slow-wave sleep during which your brain would otherwise be clearing amyloid beta through the glymphatic system. The inconvenience of a sleep study and the adjustment period of CPAP therapy are not proportionate to the biological cost of leaving obstructive sleep apnea undiagnosed and untreated for another year, or 5 years, or 10 years. Make the appointment this week. Behavior 4. The afternoon caffeine. You drink coffee at 2 in the afternoon, sometimes 3, occasionally later, because the post-lunch fatigue is real and the caffeine reliably addresses it. Caffeine's mechanism is competitive antagonism at adenosine receptors. It blocks the adenosine receptors responsible for translating accumulated homeostatic sleep drive into the subjective experience of sleepiness. It does not eliminate the adenosine accumulation. It temporarily masks your awareness of it. The caffeine consumed at 2 in the afternoon has a half-life of 5 to 7 hours in the average adult, and a substantially longer half-life in many adults over 60 due to age-related reductions in hepatic caffeine metabolism. This means that half of the caffeine from a 2 o'clock coffee is still active in your system at 7 or 8 in the evening, directly competing with adenosine signaling at the very receptors through which the homeostatic sleep drive, built up across your entire waking day, is translated into the subjective experience of sleepiness that initiates sleep onset. You are pharmacologically suppressing your own sleep drive during the precise biological window when that drive should be peaking and pulling you toward the deep, consolidated, slow-wave rich sleep that your body needs. Caffeine afternoon, that is the line. If this adjustment reduces your afternoon productivity, the solution is not to continue the late caffeine. The solution is to fix the sleep that is making the afternoon so difficult in the first place. Behavior 5. The accepted insomnia. You lie awake for 30, 40, 60 minutes after getting into bed. You wake at 2 or 3 in the morning and cannot return to sleep for an hour or more. You have been doing this for years. You have mentioned it to your physician. You were told it is normal for your age, or given a sleeping pill that makes you feel groggy the next morning, or given no intervention at all. And you have accepted it, because several people with authority told you it was normal. And because addressing it feels complicated. It is not normal. It is a clinical symptom of hyperarousal, of poor sleep hygiene practices, of circadian desynchronization, of unaddressed underlying medical contributors. And it is responsive to targeted intervention, specifically cognitive behavioral therapy for insomnia, the most evidence-supported treatment for chronic insomnia in the older adult population, with effectiveness demonstrated across multiple randomized controlled trials and endorsed as the first-line treatment by multiple national clinical guidelines before pharmacological options are considered. Cognitive behavioral therapy for insomnia is available through trained therapists, through digital programs validated in clinical trials, and increasingly through primary care practices with trained practitioners. It does not require indefinite pharmacological treatment. It addresses the behavioral and cognitive contributors to insomnia directly, producing lasting improvements in sleep quality that persist after the therapy concludes, unlike pharmacological sleep aids, whose benefits cease when the medication is stopped. You have been accepting a treatable condition as an untreatable reality. That ends with this conversation. Here is where everything you have heard today either becomes the beginning of a genuine change or becomes another piece of health information that you found interesting, filed away somewhere in the back of your mind, and did nothing with. Most people will do nothing, not because the information was not compelling, not because the interventions are not accessible, but because the gap between understanding and action is where the majority of health intentions go to die. You have been waking up exhausted every morning. You have been calling it aging. You now know that it is not aging. It is a specific, identifiable, clinically addressable combination of circadian desynchronization, sleep architecture degradation, unaddressed medical conditions, medication effects, and behavioral patterns, each of which has a targeted, evidence-based intervention. The question is not whether you can address this. You can. The question is whether you will. Here is what action looks like. Not sometime, not when you get around to it. Starting today. Today, you set a fixed wake time and you commit to it for the next 30 days regardless of how the previous night felt. You choose a bedtime that allows 7 to 8 hours in bed before that wake time. You write both times down. You set an alarm for the wake time. You commit. Today, you identify every screen in your bedroom and every screen-based activity you engage in after 9 in the evening. And you establish a hard cutoff. 90 minutes before your target bedtime, screens go off. Not dimmed. Off. Today, you take an honest inventory of your morning fatigue symptoms alongside any snoring, morning headaches, dry mouth, or daytime sleepiness, and you call your physician's office to schedule an appointment specifically to discuss these symptoms and to request evaluation for obstructive sleep apnea. If you have been waiting for a reason to make that call, this is it. Today, you write down every medication you take and the time you take it. And at your next physician appointment, you specifically ask whether any of your current medications affect sleep architecture, melatonin secretion, or nocturnal arousal patterns, and whether any timing adjustments or alternative agents might address medication-related sleep disruption. Today, you make the single behavioral commitment that has the highest ratio of evidence to effort in the entire sleep health literature: fixing your wake time, going outside within 30 minutes of waking to receive morning light, and beginning or continuing a morning aerobic exercise practice that directly addresses the circadian, hormonal, and slow-wave sleep mechanisms driving your morning fatigue. These are not suggestions, they are prescriptions, grounded in decades of rigorous science, validated across thousands of studies, and entirely within the reach of anyone who is genuinely committed to no longer accepting preventable exhaustion as their daily reality. You have spent years waking up tired and concluding that your body has failed you. Your body has not failed you. It has been sending you the same distress signal every morning, specific, informative, and addressable, and you have been translating that signal as defeat when it was always asking for intervention. This is your intervention. Wake up tomorrow and do something different. Because every morning you wake up exhausted and do nothing is a morning you chose exhaustion over the evidence-based alternative that was always available to you. The choice is entirely yours. It always has been. I am asking you to make a different one, starting tomorrow.